Hi, everyone. My name is Solome Tibebu. I'm the host of the Behavioral Health Tech Conference, and I'm so excited for our opening session today. Welcome, Brad Kittredge from Brightside Health. We've got a wonderful discussion ahead. To get started, maybe we can do some introductions. Can I have you share a little bit about yourself to get us started?
Of course. Thanks, Solomon. Really glad to be here. I'm Brad Kittredge. I am co-founder and CEO at Brightside Health. We are a national telepsychiatry provider focused on using technology, data, and a premium clinician network to deliver measurably better outcomes at scale, really helping to solve some of the hardest problems in mental health care delivery, and primarily focused on individuals with high severity and acuity that are driving a lot of our challenging and recurring, high cost and clinically ineffective events like ED visits. So really excited to be here and dig a little deeper with you.
Wonderful. Thank you. So there's certainly been a lot of growth in digital behavioral health care in recent years. Tell me a little bit about your take on how the market has been evolving and changing.
Yeah, as we all know, this is a really interesting, challenging, complex market we're working in. And many of us in this industry have set out to solve an access issue, knowing that it's really hard and as an individual seeking mental health care to find a timely appointment, particularly with someone who accepts your insurance. And I think we've set out in many ways to try to solve this. But as we've worked at this problem for many years now at Brightside, I've come to believe that the issue is deeper than really just thinking about access as the surface level problem, that really we've been in a few phases of this market. The first being emblematic of the last few decades of what I would really describe as gridlock, where the mental health care delivery and payment market is really dysfunctional with the different parties at odds. And we've been lacking breakthroughs to open up new avenues to get care. One of the symptoms and byproducts of that is the access challenge that's so visible and that we spend a lot of time talking about. But in order to really understand it, I think we need to dig down a little bit deeper and find the right unlocks for that gridlock. I think we then, have had the luxury and to some degree the silver lining of the last couple of years where a rise of consumerism and then really ignited by the COVID pandemic shifted a lot of people's consumption of services, in particularly in behavioral health, towards virtual solutions and really fundamentally changed the market in a sustained way, and showed us that we can move the needle on access issues, but maybe haven't yet addressed some of the other underlying causes that have been driving that gridlock. And what that does is it positions us in this next phase that I would argue has already begun to really materialize, where we can really manifest a lot of the potential of digital health solutions to solve many of these longstanding, costly, and intractable problems that have made it so hard to innovate in behavioral health delivery.
This is a great overview already, but can you break it down a little bit more? What's causing this traffic jam that's preventing people from receiving the quality care that they need?
Absolutely. Happy to talk a little bit about that. When we look at the market, sorry, my slides are advancing a little bit slowly. When we look at the market here, obviously it's very hard to take such a dynamic and multifaceted market and distill it into 3 points on a slide. But I think there are some forces at work here that are really important to call out, and to me, some of the fundamental drivers of this gridlock. Again, we talk a lot about the shortage of in-network care and options. If you're an individual seeking care, your experience is generally, you may go on your payer's provider directory and find a bunch of provider names listed and then call a bunch of them, and in most cases get no answer and no callback, or if you do get an answer, your next appointment is probably 12 weeks out and not really helping you solve your problem now. And then you might be, desperate enough and have the ability to go find a provider who only accepts cash, and may have an appointment sooner, but you're not able to use your benefit. And so, that is the very visible pain point that we hear about constantly. When we back in through this cycle, there are a number of drivers of that. Also very visible is the fact that reimbursement rates for behavioral services tend to be pretty low. They're frankly, lower than similar sort of per minute clinician adjusted reimbursement rates for things like primary care services. And so we've got to ask ourselves, why are rates lower here? It's easy to point the finger at payers. Payers and pharma tend to be our convenient villains in healthcare. But I think of our payer partners as largely rational actors. And I think that the low rates are not the entire explanation of what's going on. If you back one step earlier in the cycle and we look at the way mental health care has been delivered for a long time, largely it's been thought of as more art than science. And it's lacked a lot of the rigor that payers have come to expect in partners helping to address and manage chronic conditions. And if we look at that, we know that really guess and check prescribing has been the convention in care. Very few patients get therapy that's consistent with evidence-based practices. I've seen 10% as sort of the top end estimate here by academics, and very few providers still are actually even measuring their outcomes. And so what we have is this market where there's a lot of demand for mental health services, and payers could essentially just keep paying billions and billions of dollars and sort of never satisfy the demand here. But the challenge is they have no visibility into an ROI. To them, it seems like a sort of unending cost and loss. And so the only levers they've had, because they've been flying blind with no data, no accountability, no transparency, is to try to keep rates low and to try to some degree manage utilization. And they may not be able to admit this or want to admit this publicly if it's an unpopular strategy. But we also need to look at the way that care has been provided and whether payers have had partners on the provider side of this equation or in this cycle to step up and add the rigor, structure, and accountability to mental health care delivery that essentially give payers better line of sight and understanding of where there is an ROI in behavioral health and business cases and use cases with both clinical and financial returns where payers can happily invest and to make rates functional and appropriate in this market. And so in doing so, by leveling up the way care is provided, I think we have an opportunity to bring payers to the table to pay for it appropriately. And in doing so, unlock the sort of surface level access problem that's been intractable for so long.
That was a very helpful explanation. Now, what about telehealth? How has that changed behavioral health care in these last few years from your perspective?
Yeah, as we know, telehealth has been one of our strongest hypotheses of the ways that we're going to improve access to care. Many people have heard, these stats and these quotes around how many Americans live in shortage areas and have trouble finding appointments. We also know from past studies that on average, people wait at least 10 years from the onset of their symptoms to their first encounter. And there are a lot of different reasons for that have made it harder for people to access care that are both structural and real barriers as well as cultural barriers. When COVID hit and as sort of part of an upswell of consumerism in healthcare that I would argue started back closer to 2010 in a really meaningful way, we saw these forces come together where all of a sudden virtual care for behavioral health was at the forefront. And a lot of patients and providers quickly switched here. We saw telebehavioral health emerge as sort of the most used telemedicine vertical. So, accounting for 55% of behavioral health claims today after the pandemic. With most of the payers I've talked to, it reached a height of about 60% during the pandemic. So it's had a small, but to me, not very notable fall off compared to other service lines that may have had a spike during the pandemic, but post have fallen off much more notably. So we've had this sort of durable and resilience of this switch of care to virtual for behavioral. And that is, really both patients and providers in many cases saying that they enjoy it and prefer this type of care and that they can be very effective at it. So in parallel with that, we've also seen increases in visit volumes, more people seeking care. I think what we can conclude out of this is to some degree, we've been successful as an industry through offering virtual care and making it more available to really helping move the needle on access as a starting point here. More people are able to get appointments sooner and be seen. And we're seeing a shift from traditional care models to virtual care models as a durable part of the way that healthcare is evolving. And so to me, there are promising signals that these approaches are moving the needle on access and helping to address some of those concerns. But notably, I would argue we haven't yet started to address some of the other underlying drivers in that cycle of dysfunction and gridlock. And if you think about this trend from a payer standpoint, you've got more volume coming through your behavioral practice, even more demand for these services and easier to access services. So you've got more claims. And if we just keep going with this trend without addressing the ways that payers are thinking about this problem and the ways that they want to lean in and solve specific use cases and challenges in behavioral health, this is unlikely to be sustainable. And there are potentially hints out in market already of sort of companies and trying to think about what does the next phase entail and how do we make sure we can rationalize and continue to afford care and balance access and quality. And so, I think we can talk about this as a step forward for the industry, but it certainly can't be an end state. We can't assume that we have solved for all of the necessary inputs to get where we're trying to go.
Right. Seems like great progress, but still quite a bit of work to be done yet. So can you talk a little bit about what does this next phase entail?
Of course. I spend a lot of my time thinking about that, trying to figure out, of course, what's next? How do we align incentives? How do we address some of the fundamental root causes of the both access and quality issues in the space to finally unlock where we're all trying to go together? And so my prediction of really what this next phase will entail is building upon the successes that we've had over the last few years. Of course, those are major and meaningful gains in opening up new ways to deliver care and fundamentally getting the right payment models behind them. But in order for them to really be sustainable and to have the broader healthcare system really embrace them in the way we know is necessary at the scale that we think this problem is at, we need to move across each of these axes from a starting use case to really, the harder, more integrated, more complicated and expensive use cases, but the things that are driving really the bulk of healthcare costs. And, that is, being able to support Medicaid and Medicare, that is being able to work in collaboration with health systems and payers and other stakeholders that are driving care for complex cases. That is being able to use screening and population health management to identify cases where there is a need and an opportunity to intervene early and deliver impactful care rather than our traditional model of sort of waiting for people to show up and book an appointment. And fundamentally, I think a lot of these really ladder up to actually unlocking the path from fee-for-service into value-based payment, where we have the opportunity to shift, given the new care models we have and the tools we have available, to a model that is less about volume as the measure of negotiating leverage and value creation, and really about other measures of value that we know are aligned with clinical outcomes and certainly directly contributing to or correlated with financial outcomes. This is going to be a huge shift for us, and we've talked about it for a long time. And I think we've all been hoping for a long time that we'd be able to move into these kinds of payment models. I fundamentally believe we are actually at that point where this is starting to happen, where payers are very interested and eager to migrate contracts to be risk-bearing in a number of different ways, or at least aligned with supporting and requiring a higher bar for care rigor and quality and measurability. And that there's a base of providers now who have the sophistication and the tools to be able to step up and do that. And so we see providers going into the complex areas of care and the programs that often are more challenging, moving beyond kind of the straight up the middle cases of therapy and into the clinically rigorous, financially expensive cases that really move the needle. And I think this is the beginning of really the maturing phase where digital behavioral health and virtual care delivery sort of cements its position as a core part of the future of care delivery in the U.S.
These are all really important points, but of course, things that I know have been really difficult to achieve in the past. what makes us ready to be able to do these things now?
Yeah, that's I mean, I think that is the key question. And so, as we think about that gridlock and what would unbreak the gridlock and what a healthy cycle would look like here, we know healthcare is not an efficient market, and in some ways will never be an efficient market, but we can find pockets of efficiency and incentive alignment. And fundamentally, I would argue that that's what breaking the gridlock is about, is finding incentive alignment. And that is, clinical and financial incentives. And so again, we have a range of proof points. We have a good amount of data as an industry now, both on the provider side and on the payer side, to have growing alignment around certain use cases, certainly, and certain models, that we have not only optimism, but sort of organizational commitment behind them on both payer and provider examples, to be able to break through and to deliver care in a different way. So from our lens as a provider, that starts with what parts of this can we control? How can we show up to the table with payers and other providers in the ecosystem and bring a care model and evidence of the impact of that care model that we think can fundamentally move the needle both clinically and financially? And where you can align incentives is where you can motivate people to make that happen. And we're seeing that with payers, we're seeing that with health systems, and more and more across other segments within the industry. And so as we raise the bar on the quality of care together, which means controlling for variability at scale, having visibility and transparency and accountability with measurable outcomes, adherence to safety standards, and everything that really the healthcare industry wants to see. As digital health grows up here and leans into this phase, we bring much more incentive alignment and credibility and commitment to the table, and really, I think, unblock that opportunity for payers to lean in and to align with pricing models that reward quality and value creation. And in doing so, really unblock, what I would argue again is more of the symptom than the cause, being the difficulty finding appointments. As we have these care models, as we have these payment models, in most cases, there are solutions for the way that the care can be delivered. Psychiatry tends to be the most impacted specialty within the space. That looks like it's only going to worsen, but we have a lot of other provider types. We have a lot of evidence of the potential opportunity to use those different provider types in effective ways. Everything from psych NPs and therapists down to coaches and peers and even family members and peripheral support. And that the delivery model plus the incentive alignment open up a lot of opportunities to use those levers to solve the provider shortage and the access challenges that have been difficult for so long. So I am not only hopeful, but optimistic. And from our seat at Brightside, we are committed and pushing hard to make this the new reality and to finally break that cycle of gridlock.
Yes, I too am optimistic. This is really an important moment in time. And I love the question that you asked, that you said, you're asking your team of what is our role in all of this? And I hope that through this conversation and the many others taking place at the Behavioral Health Tech Conference, that each of our stakeholders can ask that, because it is going to require that of all stakeholders to move this progress forward. But I just want to thank you, Brad, for your leadership at Brightside Health and this excellent overview of industry and the trends. Thanks so much for your time.
All right, glad to be here. Thank you, Solome.